Good morning, everyone, for this interesting session. Second day, you see a good number. I hope you are enjoying the meeting. And without further detail, I would like to introduce my colleagues and the session today and the objective of the session, align to line, improve clinical outcome of current and future patient with Evolut platform Medtronic. I have Dr. Baumbach from UK as a chairman with me, Khalid Almerri from Kuwait, Haytham Amin, Muhammad Balghith, Dr. Thomas, and Sundu Samargandi. We are happy to have you guys with us, and it's going to be a very interesting session. The learning objective of this session is to reveal the exceptional performance of Evolut PRO, to learn key considerations for patients with longer life expectancy, to explore the pathway to a single-digit pacemaker post-TAVI. With our first speaker, Dr. Khalid Almerri, you should go ahead.
Good afternoon, everybody. So what I'm going to talk about is what are the changes that happened on Evolut PRO Plus and what are the impaction on patients' care. I have no conflict of interest. And basically, the changes on the new Evolut PRO Plus is basically two things. If we look to the size 23, 26, 29 Evolut platform, Evolut PRO was the delivery system was 16 French in size. And with the Evolut PRO Plus, we managed to get it down to 14 plus, which is equal to the size of Evolut R. The other change that happened on Evolut PRO Plus, now we have a skirt on size 34 Evolut. Before, with the development or changes in the Evolut platform, there were skirts on the only size 23, 26, 29, and the size 34, there was no skirt on it. So now we have skirt on all the sizes, but on the expense of the increase in the delivery system size from 16, it was, I want to move the 16 here, Evolut R34, now it is 18. So we increased the size of the delivery system, but the valve now has a skirt on it. How that is going to be reflected on the patient, that we're going to see that shortly. How it was done, it's basically, the inner lining of the capsule was lined with PTFE material to make it more slippery, so that we can squeeze the Evolut PRO into a smaller area. So the delivery system is an Evolut R with a squeezed-in Evolut PRO. But the frame is the same, the leaflets are the same, the material is the same, nothing has changed in the valve itself except a skirt on the 34, and the height of the skirt on 34 and 29 is 14, as usual on 29, and 13 in the other sizes. It will, as I said, the valve itself, there are no changes on it, so it covers the same annulus range with a smaller delivery systems. How can the change in the sheath size affect the patient's care? Basically, we used to require, or the requirement for the size 23, 26, 29 Evolut PRO was the minimal access size should be more than 5.5 millimeters. And the outer diameter of the delivery system was 6.7. Now it came down to 5, and the outer diameter is 6. Whereas the Evolut PRO Plus, it has gone up from outer diameter 6.7 to 7.3, so the requirement of the vessel size has gone from 5.5 to 6. How is that important? So managing to go down on the minimal vessel requirement from 5.5 to 5, we could include 10% of patients with severe aortic stenosis can be treated with the new changes in the Evolut PRO Plus platform. And it's well known and well documented the sheath to iliofemoral artery ratio matters and a major predictor of vascular complication. And going down with the delivery system size, definitely that will improve and reduce that major vascular complication. And if we look to the optimized PRO, it's a prospective an unrandomized trial where PRO Plus was used with application of the Cusp overlap technique. And in that study, we could see the major vascular complication is really minimal, 0.6 to 1.4. And just a side note here is we could see the permanent pacemaker implantation now is single digit, and basically because of the technique, Cusp overlap technique, which Dr. Cuisset will talk about in the next lecture. But if we look again to the PRO Plus, this is a paper that was presented in Evolut PCR with PRO Plus major vascular complication. We can see the major complication is around 1.1%. What about the adding the skirt to size 34 valve, which is aimed to reduce the paravalvular leak? And we all know that moderate to severe aortic valve regurgitation post-TAVI increases mortality and cardiovascular events, and that has been shown in multiple studies and meta-analysis. And we used to think that mild AR is acceptable. We have some data now, maybe it is not, despite we have seen in the SURTAVI 5 years follow-up by Dr. Baumbach that it was not affecting the major outcome, but we have some signals now that mild AR should be tackled and try to avoid that. And that has been shown in big meta-analysis and multiple trials. To prove the concept of adding a skirt to the Evolut platform was shown when we compare Evolut PRO, which has a skirt on it, to Evolut R in size 23, 29, 26 valves. We managed to reduce the moderate to severe AR significantly. So the concept of adding skirt to improve paravalvular leak was done at that time. Now, in looking at the Evolut PRO Plus, how does it behave compared to Evolut R? And we can clearly see with Evolut PRO Plus, all sizes, we can see the aortic regurgitation has gone significantly down with it. What about size 34 specifically compared to Evolut R size 34? And clearly, the new skirt added to Evolut PRO Plus size 34 significantly reduced the risk of mild to moderate and severe AR. Another group of patients are bicuspid valve patients. And in Evolut X registry, 1/3 of the patients they needed size 34 valve. And we know bicuspid valve patients, they have higher risk of paravalvular leak. And this group of patients would benefit from adding a skirt to the platform size 34. And again, if we go back to optimized trial, which is the prospective non-randomized trial looking into the PRO Plus, moderate to severe AR paravalvular leak was 0%. In summary, Evolut PRO Plus size 23 to 29, we had reduction in the capsule, and the vessel requirement is less, so we can treat more patients with less vascular complication, whereas Evolut PRO Plus size 34, a skirt was added, so that will tackle the paravalvular leak. Thank you very much.
Thank you, Dr. Almerri, for this nice presentation. And I will go for a few questions. First of all, how many of the audience have used already PRO Plus? Any of the audience? Okay, so it's a very small number of us. So going straight to the questions. Have you used, Dr. Almerri, any PRO Plus since, or?
Yes.
Yes,
Yeah.
okay, that's great. So I'll be questioning to you and also the other of the panelists. Now we have Pro R and Pro Plus. What is your go-to points in selection? What is best for the patients, or each of these one?
I think R and Pro Plus now are the same, except one has a skirt, one doesn't have a skirt. And I would go with Pro Plus. One major thing that we faced when we start using Evolut R, the delivery of the capsule through tortuous calcified vessels was easier. When we moved to the Evolut PRO, which is a bigger capsule, we had difficulty of negotiating the tortuosity with calcification with this bulky capsule. Since now we went back down on the size, we have tested that, and it's really easier to go with the delivery system through those vessels. And if we have both, I would use Pro Plus because of the presence of the skirt, and we have evidence that reduces the paravalvular leak.
Any other thoughts from the panelists? Yes, Dr. Balghith.
I think most of the challenges we have in the cath lab regarding the sizes was with the 34, to be honest with you, and I'm sure most of us, we faced that. You know, the problem with the increasing the sheet size. In our society, we face a vascular problem, to be honest with you, in general. But the incidence of having or when you do the CT scan, less likely in comparison with the vast majority. Most of the patient, we deploy 26, to be honest with you, and 29 in this society. But I think we're going to need the 34, but it will be in less number of patients. We use shockwave. We have more experience with ballooning, with dilating, with the dilators, and we overcome some of the problems in a safe way.
Dr. Wael, since you have like a vast experience in the cusp overlap, which Dr. Merri has mentioned, with the addition of this skirt, there's always a concern of the pacemaker and stuff. So what is your thought?
Honestly, since we adopt the cusp overlap technique, we started very early, end of 2018, beginning of 2019. We found really the rate of permanent pacemaker went down to single digit. We published our first 50 case. The pacemaker rate was about 15%, the first 50 cases without cusp overlap. Then, since we started the cusp overlap, we just finished writing up the first 100 patients. Our number is 6.2%. That's a very good change, and you know, like we were able to bring down this based on the cusp overlap. I think every implanter, in my opinion, should adopt this technique. It is exercise yourself, like I said, spend time in understanding this cusp overlap, and the commissioner alignment, of course. It really pays off. A very interesting technique and a very good result.
For the rest of the Thomas, or also Dr. Andres, what about, which is not tackled, the coronary accessibility and chromosomal alignments? Is there any difference, you think, with the PRO? You can start.
No, as we nicely heard, I think there is no much difference in the valve, so I think we should still apply what we learned from the Evolut Air and the Evolut PRO, so meaning the commissural alignment, the depth of implantation, and especially that I've seen that in the Gulf, you are treating probably younger patients that we have.
Yes.
In France. The mean age was 82 last year, and but now we are treating more and more younger patients with longer life expectancy. Then coronary access is probably even more important than when we treat older patients.
No, I think that there's no difference in that particular aspect. And we should continue with the technique. And I think the most important thing is that we adopt and learn, and we're going to hear how to do it in a later talk, because frankly most people just aspire to do it but not really follow through, and I think that's the next step.
So with that, Dr. Haytham, do you have any final before we conclude this session and go to the next talk?
Looking forward to seeing the technique shown by my colleagues at the end of the session.
So without further ado, we'll move to the next speaker. It's my pleasure to introduce Dr. Mohammed Balghith, our senior consultant from National Guard Hospital in Riyadh. And he will be telling us today about the durability. Is it the key issue? Choice of the first valve matters. The floor is yours, Dr. Balghith.
Thank you very much. I have no conflict of interest. There is a major difference nowadays in the guidelines for TAVI between the European and the newly published American guidelines. As you can see here, they mentioned the age and they went down to 65. At the same time, also they involve the life expectancy and durability in the guidelines. The definition for valve failure, it was published already by our colleague from Europe. And what they did a joint statement from the European Association of PCI and Cardiothoracic Surgery, and they defined the concept of SVD, structural valvular dysfunction, based on the identification of structural and hemodynamic valve deterioration at the echocardiographic follow-up, and they introduced a new concept of bioprosthetic valve failure. The valve failure, as you can see here, it could be structural from the valve itself or nanostructural. The nanostructural, mainly the prosthesis patient mismatch or the paravalvular leak, which we are familiar with it, all of us. And they added to it the thrombosis endocarditis, and those will lead to severe permanent HVD, which might result in re-intervention or death related to the valve dysfunction. The SVD criteria, as you can see here, stage 0 and 1, it's okay, but stage 2, the moderate hemodynamic SVD, you have to have a final gradient more than 20 millimeter mercury or reduction in the effective orifice area more than or equal to 0.3, and the severe one is final gradient more than 30 and the reduction in the effective orifice area more than or equal to 0.6 centimeters square. We know from the surgical data that the probability for reoperation, it's more with the younger people. If you are young in the age of 50, you will have the higher probability for reoperation due to SVD. If you are in the late age, like our typical TAVI patient, less likely you will have severe SVD. Again, this is the data from United States showing you that the durability, even for the surgical bioprosthetic valve, is different from one valve to one valve, and the best valve here at 15 years follow-up performance was best for Edward Primount. There was more new valves, but unfortunately, they discover more failure, and some of them removed from the market, like Trifecta. The STS surgical PPM, as we can see here from the surgical data, the severe one was around 11% among this registry or trials, which involve a good number of patients, about 60,000. And BBM significantly decreased the long-term survival and increased the readmission rate for both heart failure and reoperation for AVR. Why we are interested in durability? Because most of us, you see, we are interested in the TAVI, and our patient, they come to the clinic, they want TAVI. They are more aware from the media, from their people who had, or their relative who had, is a less invasive than surgical replacement. And you can see the increment of TAVI in comparison with the SAVR. It's a huge and dramatic change in the number of patients who underwent such procedure. The lifetime management and metrics, it's very important for us when we compare the low-risk, younger patients, 65 plus, and more bicuspid, higher activity in comparison with the extreme risk, high risk, and intermediate. In those younger people, we are more interested in hemodynamic, PPM, durability, life expectancy, coronary access, in comparison with the elderly people and higher risk patient, where our major concern is the procedural success, like mortality, stroke, quality of life, and permanent pacemaker. We know from the low risk Evolut trial that the self-expandable like Evolut, they did better in comparison with the surgical valve regarding both the gradient and the effective orifice area in both 2 years follow-up and even at 5 years follow-up. And this effect was, especially the gradient was more with the balloon expandable in comparison with the self-expandable. The ppm in 60,000 patients in the STS-ACC-TV registry, you can see it is it's related or having more. If you have a severe ppm, the mortality rate will increase at least at 1 year to 17%, and also the heart failure readmission increase up to 12%. Yesterday we heard a lot of talk about women and smaller annulus. The ppm was observed more in women in this TAVI registry, and if you compare both technology, it was more obvious in balloon expandable in comparison with the self-expandable, which is supraannular type of valves. And again, the outcome was more severe and obvious in women. The outcome of death, stroke, and rehospitalization. Also, this is a comparison between the effective orifice area in both balloon expandable and self-expandable. It was more obvious in balloon expandable type of valve. This is a new trial. It's ongoing, enrolling a SMART trial. We heard a little bit about it yesterday. They will compare the smaller annulus, and they will get the two technology head-to-head together. This is the first time we will have a result of such trial. Again, this is a Sabian versus surgery. This is a partner to 5 years follow-up. You see more SVD in the Sabian in comparison with the surgical valve. And this is outcome of TAVI, which is intermediate trial, showed you a better result in favor of self-expandable in comparison with the surgical trial, surgical prosthesis. The Notion trial, this is one of the most obvious trial regarding the durability, and started long time ago. It was intermediate, it was low risk patient, started in 2013. We have a follow-up for 8 years. And this is the first time we have a follow-up for durability of the TAVI patients or TAVI valves. And you can see a good result, significant p-value in favor of TAVI in both core valve, in both in the gradient and the effective orifice area. Also, the SVD was better in TAVI in comparison with SAVR in this Notion trial. The new rule or phenomena of leaflet thrombosis and Holt and hypoattenuation was discovered in the Cedars-Sinai people, Makar and his group. Then they went back to the bioprosthetic valve and they studied the other TAVI. And as you can see here from partner 3, there was, in the first month, there was a better result for a surgical valve in comparison with the Sabian, but at 1 year there was no big difference. And in Evolut low-risk leaflet, the thrombosis and immobility was studied in that trial for the self-expandable, which is core valve. And again, there was a better result in favor of self-expandable. This is a meta-analysis which was presented yesterday. They included most of the trial we have, and they concluded that that self-expandable valve had lower risk of SVD compared with the balloon expandable and SAVR. And as we can see here in conclusion, that the durability of TAVI, the durability of bioprosthetic aortic valve is important, particularly in young patient who will have a longer life expectancy. And I think we are very interested in this area because our patient always younger, both in presentation with aortic stenosis, and also same, we have the same thing in the PCI era. Self-expandable with supraannular leaflet position offer the largest effective orifice area and the lowest transgradient pressure gradient. And this seems to transform into a lower rate of structural valve deterioration and valve failure as compared to both balloon expandable and surgical bioprosthetic aortic valves. The longer durability data for bioprosthetic aortic valves are needed for planning of a lifetime management of patients with aortic stenosis. Thank you very much.
Thank you, Dr. Mohammed, for this excellent review. As of the last 2 days, as I've been looking at all my colleagues describe, who are much more experienced than me in structural heart disease, that we have started to mature both in our procedural steps. We are modifying the way we implant the stents. We're using the Cusp overlap to get commissural alignment, to have a higher implant. And this translates into, future access for the coronary vessels, decreasing pacemaker requirements, and permanent pacemaker by itself has its own morbidity, across the years. And of course, the improvement in the technology itself with the extra skirt, as Dr. Khalid showed, and of course with the preservation of the leaflet itself so that it becomes, more durable. So I think this is technology and an experience in evolution. We are improving and modifying as time goes on, and I think what you showed, Mohammed, supports this concept. And of course, the TAVI data that Andres mentioned today showed the long-term durability of this platform. So I just had this comment. I don't know if any of my colleagues had any questions to Dr. Mohammed or anybody from the audience.
Maybe short question or comment. We've seen that you have probably in the region more people with small annulus, and probably the SMART trial will bring us some information. But I think that we are in a difficult situation because we want to put self-expandable valve for durability and for lower mismatch. But meanwhile, we have the feeling that TAVI is not one-shot procedure anymore, and we have to think like playing chess. We have to think to the next shot. And yesterday we've seen that for TAVI in TAVI, probably the other way around might be the best option, meaning balloon expandable followed by self-expandable. So I think it will be really the challenge of the coming years, that we have pro and cons for each valve, and so we have to think the long term, probably.
I think the practice, we learned a lot. When we started the TAVI, like at least in our center 11 years ago, we get the CT scan people, we traveled to Europe, and then even the protocol for doing CT scan improved by the time. And I think we have to keep in mind the mismatch. You could have it even in TAVI. Like yesterday, they put 23 and they increased the volume. And some people, maybe in the same room, they might go for a bigger one than 23. We deploy, to be honest with you, like smaller valves and some of the ladies, and we are concerned. That's why I think those people who had a smaller valve, they should have a very close follow-up and close frequent type of echo.
I think what was really an eye-opener for me yesterday was this discordance between the invasive hemodynamic assessment of the transvalvular gradient and the echo. And we've always based our decisions on ppm with the echo gradient. So I think this will need to be resolved for us to really learn more about. So this was an eye-opener for me. It's a paradigm shift in the way I look at how do I assess, any valve, but mainly an implanted, bioprosthetic valve with a gradient. So, how do my colleagues, settle this issue between echo gradients and, the golden standard of an invasive gradient?
We see this commonly. You finish the procedure with peak-to-peak gradient 0, and next day you find a gradient of 9 or 10. And sometimes we think, well, maybe it is a recoil. or it is just the pressure after recovery that we are dealing with. So that we have been facing it. Just going back to durability and choosing the best valve in somebody that might need another procedure, we may argue about, well, to have the lowest pressure gradient valve, that can give you more years. So if you choose a supraannular valve with low gradient, you can maintain it over years, and single digit, maybe that will stay longer with the patient.
I think that's a very valid point, Khalid. I think there is no one right way and no one wrong way. I think you have to understand each valve, how it works, how I prevent complication like putting a permanent pacemaker with each valve. You have to read your patient, the membrane septum length, the degree of the expansion of the or overexpansion of the valve itself, how deep you're gonna go. Like all this, you have to take the entire picture. It's not like, okay, tomorrow I'm gonna do a TAVI, because really now it's a big problem. We are putting the valve for younger people now. By the way, younger here is older, the age. Like when we are 60 here, it's like really equal to 70 in Europe or not.
That's what we call valve journey for
yeah.
Maybe just a small comment about the gradient assessment. I think it's important for all TAVI procedure, but even more when we do valve-in-valve with small bioprosthetic valve. Because sometimes you just do peak to peak and then you say, okay, it's 8, and then the next day you have 18. And then you think, oh, I should have cracked the bioprosthesis. So I think for valve-in-valve in small bioprosthetic, it's very important to take time and probably to do both.
We noticed that even in the other valves, not only valve-in-valve aortic, also in tricuspid and in mitral. Yeah.
Thank you. So I think on that note, I will call to the podium my colleague, Dr. Thomas Cuisset, who will talk about how to reduce conduction abnormalities by showing us the cusp overlap technique step by step.
Yeah, thank you. Thank you, Ilham. So indeed, in the next few minutes, we'll try to see how the new implantation technique with the Evolut platform, which is called the cusp overlap technique, can help us to reduce the conduction abnormalities. And as we've discussed, as we're treating younger patients, that's really, I think, something we should target in our TAVI activity. So try to divide the talk in two different parts. The first one will be really practical about the concept and the different steps of the cusp overlap technique. And after to see the, let's say, emerging evidence showing that using this technique will really improve patient outcome and reduce the rate of pacemaker implantation. So just starting with the concept and the technical aspect, I think the first question is, why do we need a new technique for Evolut implantations? The idea is to move from the conventional tricusp view that we use for years to a new cusp overlap view overlapping the left and the right coronary cusp. And what's the value of this new technique? I think there is two. Probably the main one is to use as a landmark the lowest part of the non-coronary cusp to achieve higher and also more accurate positioning of the valve. And therefore, if we put higher implantation, we will of course reduce conduction abnormalities. But I think that beyond the reduction of pacemaker implantation, it's also good to share and to discuss, because years ago, everybody has his own way to put the Evolut valve. But today, thanks to that, I think we have a nice harmonization of the implantation technique. And that will be easier, I think, to share, but also to teach in the coming years. So the first step, as anything for TAVI, the first step of the cusp overlap technique is starting with the CT analysis. And using the S-curve, exactly as we used to do for the tricusp, we will try to define the good projection for the cusp overlap technique, which is very often aero and caudal projection. So sometimes it's difficult because you have the tube on you, but usually it's aero and caudal projection. So then, according of course to the renal function of the patient, in my practice I don't do it every time, but if we have patients with good renal function, especially if you start using this technique, I think it's good to do the two view, the tricusp and the cusp overlap technique, really to realize the difference between the two projections. I think the next step, and I think it's probably an important one in the cusp overlap technique, if very often we start the deployment putting the valve at the annular position, on sometimes even 1 millimeter under the annular position. But with this new technique, the new recommendation is to start with the marker at the mid part of the pictal. It means that we will start at supraannular position and we will let the Evolut dive toward the LV to reduce interaction between the valve and the conduction system. The next part is the slow initial deployment of the two first parts of the valve up to here. And during this slow deployment, of course, we will still target depth implantation around -3. We will do that without pacing up to here. And during this phase, the valve will move slightly toward the LV. The second part, again, there was different practice about pacing with the Evolut platform, but with this technique, so we start mid-pictal, then we open 2 cells, and for the next step, let's say the mid part of the deployment, we use pacing between 120 and 140 to stabilize a little bit, and for rapid deployment, from annular contact before the point of no recapture. It means when we have the sound during the deployment. And then at this stage, it's functional, so we can take time to assess the depth of implantation in both cusp overlap, but also we can go back to the tricusp to assess the depth of implantation in the left coronary cusp. Of course, we always have pros and cons for the high implantation. Of course, the pro we discuss is less conduction abnormality, but we also have cons to put the valve at 0 or just -1. We know the coronary access might be more challenging. And also in case we need post-dilatation, which is probably 25 to 30% of cases with Evolut, then we could experience embolization. So we always have, we discussed that with DAPT, but it's the same for TAVI. We have to find a compromise between high and low implantation, and it should be probably tailored to each patient anatomy. And we should, of course, consider recapturing when we are less than -1 or more than 5 millimeters of depth, and in any case, because we want to improve coronary access or lower the risk of embolization, but of course, when we are too low, to reduce the risk of conduction abnormalities. For the last part, and to avoid any embolization, especially when we target high implantation, as we have in this case, when you see the picture, we are probably just -1. So we have to decrease the tension on the wire here, and often try to keep a small push on the valve, and with very slow final deployment. Years ago, the final deployment was sometimes quite quick, but now we say that we have probably to take at least 20 to 30 seconds for the final deployment to make it really progressive and to avoid embolization. So here again, we are probably even 0 or -1. We have good result, no PVL, and that's, I think, something we should target. We discuss a lot about the hemodynamics, but we should look always at the ECG, because we know that the early changes in QRS will be also a very good predictor of conduction abnormalities. So that's just for the, let's say, step-by-step technique for this new cusp overlap. So it's aimed to reduce pacemaker and also to have all the same technique. And what are today the evidence for the reduction of conduction abnormalities and pacemaker implantation? The first one is coming from the team of Oscar Mendes, Argentina, and they just compare the conventional implantation with the new cusp overlap technique. And they show that they were able to significantly reduce not only the rate of pacemaker implantation, but also the rate of left Bolden branch block. And we know that's also something challenging in our TAVI practice. Recently, we had another paper which, again, find this famous single-digit number for the rate of pacemaker implantation. It was around 5% in this study. And if we just want to pull all the recent study assessing the rate of pacemaker implantation using the Cusp overlap technique, you can see that the rate of pacemaker in all these recent, although small studies, for most of them, reach the single-digit number for pacemaker implantation. So just to conclude, for the technical aspect, we have today step-by-step and standardized procedure with Evolut platform. I think that's something really important. And using this specific projection overlapping the left and the right coronary cusp, we have evidence showing lower rate of pacemaker implantation in early reports, but of course, larger data will be needed. And one additional benefit also of working in the cusp overlap view could be to optimize also the second concept that we already discussed, which is the commissural alignment. And if you use the commissural alignment that we have here and here, the C-tab should be in the inner curve of the ascending aorta to have, let's say, an optimal commissural alignment. So also what we learn in the tricusp should be readjusted in the cusp overlap view to optimize the rate of pacemaker, but also the commissural alignment using the Evolut platform. Thank you.
So, Thomas, that was a great demonstration of the technique and revision. One thing you haven't mentioned, at least maybe I missed it, but how about coronary access? If you go higher and higher, is that becoming more and more of a problem, or are we in a range where that's not an issue? Has that been looked at?
No, that was exactly the slide I had to say. We need to find a compromise, because too low, it's pacemaker, and too high, it's more difficult coronary access, and sometimes risk of embolization also. So I think we need to adapt according to each patient anatomy. In patient with prior pacemaker, we will probably allow to be -3 or -4, but in patient with low coronary intake, and then we will do exactly the opposite. So again, I think there is no, as you said many times, there is no absolute rules for all the patients, but we need to nice CT analysis and then to tailor.
And then I've got a follow-on question, and then we have time for one question from the floor if you have one. I mean, you've put a number to the pacemaker reduction. Is there a number for the embolization? Is that a real risk if you go higher and higher? You know, in the old days it was, but in the new days, is it a risk? Or with the resheathing and repositioning, are we able to contain that risk?
In the paper, especially the one of Oscar Mendes, when they compare before and after, there was no difference for the rate of embolization, but it was a small number, just 100 patients. But if you put very high implantation and you want to do post-dilatation, there is also rules, meaning you need to wait really effective pacing to start inflating the balloon, and you need to wait the balloon fully deflated before stopping the pacing. So that's, I think.
I think you had a comment?
Yeah, it's regarding the risk of embolization, and we stopped pre-dilatation a long time ago, but now with the cusp overlap, we noticed that we tend to have lower threshold of pre-dilatation, especially in calcified valves, to avoid post-dilatation. So it's like a compromise, you know.
Yeah, fully.
Maybe one interesting aspect, as we're there, what is the risk? Why is there a risk with the balloon? Is it the valve foreshortens a bit further and then comes too high, or is it the balloon taking the valve away with friction?
I think it's both, because if you have a jump in the pacing and then the balloon is inflated, it can just completely bring the valve higher. So it's.
But the foreshortening is an aspect as well. I think we're coming to the end of this very, very interesting session. If I would sum up, then we have seen an evolution of Evolut. We see new valve systems with favorable size range, skirts where they belong, and a more aligned delivery system. The durability really looks good. for self-expanding valves. And then we had a deep dive into Cusp overlap, which definitely reduces the pacemaker rate, but in some patients may come at a cost of access, and we have to find an individual solution for our patients. On that note, I thank the speakers and the panelists and my co-chair, and I close this session, and I invite Aref Al-Nouriani, Jean Vajadeh, and Thomas Cuisset for the next session, which is Terumo on complex coronary lesions. Thank you very much.